Hello, everyone. I am Abd-Elsayed, and I go by Al. I'm the Medical Director of UW Health Pain Services at the University of Wisconsin, Madison. I'm very honored to be invited by the organizing committee to present 3 talks during that meeting. And while I was really looking forward to seeing you all in person, unfortunately, due to the recent surge and some mandated travel restrictions, I was not able to make it in person. I never visited Switzerland before, and I was really looking for this opportunity to meet with all of you and visit a beautiful country that I always wanted to visit. But unfortunately, the pandemic impacted all our travel plans. But I'm very honored to be here, be able to present virtually. And I hope next year I'll be able to see you all in person, and we will get to enjoy, hopefully, a world free of the coronavirus. My talk will be about advances in peripheral nerve stimulation. It's a very important topic because peripheral nerve stimulation has been the center, and the new technology is really evolving in neuromodulation in the past decade with too many advances that continues to happen every year. So let us talk first about the indications of peripheral nerve stimulation. Overall, any peripheral nerve disease, which can be neuralgias, neuropathies, any other nerve conditions, can be treated by peripheral nerve stimulation. And typically, we do it after patients consume their conservative management option like medications and physical therapy with no satisfactory effects. It's very, very important to make the diagnosis of peripheral neuralgias or neuropathy before moving forward with peripheral nerve stimulation. That requires a very thorough history, talking to the patient about their history, how did the injury start, and where did the injury or where does the trauma happened, or how did it start, and then talking even about the distribution of the pain, the feeling of the pain, was it sharp, tingling. Every single detail in the history can help us make up the diagnosis before we start even the exam. Then it comes next to the physical exam, where we need to be again performing very thorough physical exam where we identify the nerve, identify the impacted area, and try basically to identify which nerve we're dealing with. When it comes to peripheral nervous system, it's more delicate because you have the main nerves, like for example, femoral nerve, sciatic nerve, but then you have too many branches as the nerve travels distally, and you need to identify exactly which branch we would like to deal with. Then it's really highly recommended to do a diagnostic block, basically block the nerve with lidocaine or bupivacaine, any other local anesthetic, ideally under ultrasound, because if the pain improves after your numbing medicine or local anesthetic injection, then you become very confident that you are targeting the right nerve, and then working with it with peripheral nerve stimulation should yield good results. So there are different types of peripheral nerve stimulators, and honestly, every year we see more brands coming to the market. But they can be basically IPG operated system that has batteries implanted in the body. And there are wireless systems, which probably the groundbreaking technology because you don't have to implant any generators in the body, but it is applied from outside the skin and connects wirelessly to the implanted leads. Then the system can be temporary or permanent. So you can put it and remove it in a certain number of days, or you can leave it permanently in the body to provide the longer term pain relief. And the wireless technology, basically, it's made of certain elements that allow for the wireless technology to work. So you will have an internal lead, then you will have an internal receiver, and then you have an external antenna and generator. So basically, the energy will travel from the external generator to the external antenna, then through the skin and subcutaneous tissues into the internal receiver, which will take it to the lead or contacts, which are on top of the nerve or close to the nerve, which then generates the stimulation. The challenges of wire technology are the external unit, the wearables, and the need to keep it in certain proximity to the lead so it can actually couple with the lead, and the need for accessories, and the energy transmission between the external and internal components. While those maybe were really concerns at the beginning of the technology, I have to admit that with recent devices we have, they have been very, very efficient and they work very well. And they kept all those limitations in mind, and almost they became of no concern anymore. I just want to bring you to the history of peripheral nerve stimulation. That was kind of the first peripheral nerve stimulators performed in chronic nerve pain conditions. It was a big surgical procedure. So they make a big cut, identify the nerve, and then get this big lead to put on top of the nerve, sometimes suture it or wrap it around the nerve to provide peripheral nerve stimulator. So it was to some extent an extensive surgery to place a peripheral nerve stimulator. These are studies that were published probably 20 years ago and more. As you see, it goes back to 1976 and 75, where people started thinking of peripheral nerve stimulation and identified its importance. As you see here, the numbers was between 17 patients to 34 patients in all the studies. But if you look at the summary of results here, all of them showed very promising results, although they were done again. Some of those are almost 50 years ago were done, but the concept has been there. People identified the efficacy and used basically the older devices that were not made for that indication. So typically people use the spinal cord stimulators for peripheral nerve stimulation. And all of them concluded, as you said on the recommendations, peripheral nerve stimulators can be useful in addressing pain in carefully selected patients. The most dramatic success occurred in patients with peripheral nerve trauma. All of them, all the results have been very, very promising. And that's again, another example of how it was done. Basically, you cuff it all around the lead, around the nerve to provide stimulation. Again, big extensive surgery that was done at that time, but that was the best we knew at that point. Another actually case series published that shows kind of peripheral nerve stimulation targets and then the duration of symptoms. And it was done specifically on the trigeminal nerve. So between stimulating V1 or V1 and V2. And as you see, the pain relief between 6% to 100%, and the follow-up duration was up to 27 months. And again, that was done in 2012, so about 10 years ago. Then come here, the promise of the performing the procedure was ultrasound. So now several providers and pain physicians and other practitioners all around the world mastered ultrasound and the use of ultrasound in that they can identify the nerves all over the body by the use of ultrasound. So if you look here, that's kind of how we do our peripheral nerve stimulation nowadays. You just put the ultrasound, you see the nerve, and then you use the needle to go through the nerve, and then this needle will carry the lead, and then you start to connecting the different elements. And literally the maximum you do during the implant of a peripheral nerve stimulator now is maybe 2 incisions, each is 1 centimeter subcutaneous skin and subcutaneous tissues. So you can see the huge difference and the advances in ultrasound guidance, which honestly I think was the main drive in the advancement of peripheral nerve stimulation, because it became a much less invasive procedure as compared to the past and the images I showed you previously. Most importantly, peripheral nerve stimulation added a value to neuromodulation overall. Before I start discussing that slide, I want to tell you, like in the past, everything we knew was just doing spinal cord stimulation. And we could notice very well that when we try to target peripheral nerves and try to do spinal cord stimulation, it doesn't really work very well. I felt spinal cord stimulation work more when you want to deal with like nerve roots or big dermatomes or big nerves. But when it comes trying to just stimulate a peripheral nerve, a peripheral nerve stimulator proven to be more effective. But the beauty of peripheral nerve stimulation in that a case like this one here, you can actually, they were trying to target intercostal nerves. So they placed actually peripheral nerves and spinal cord stimulator nerves epidurally. This way, they got double effect in stimulating the intercostal nerves and try to achieve better efficacy by putting the peripheral element stimulating the peripheral nerves, as well as the spinal cord stimulation element epidurally. So try to target the nerves at two locations. So it gives us the way to, so we can tailor our neuromodulation and stimulation and coverage based on patient pain. Then that's another case, and that shows you, and that's a very important indication when we start talking about headache. Again, spinal cord stimulation did not have very promising results with this, but again, putting peripheral nerve stimulation around the target nerves. Again, this is just an example where they put actually multiple electrodes on each side, long leads to cover both the occipital nerves and the supraorbital, supratrochlear nerves, multiple branches all around the head. It's just I'm trying to show you here the history. We don't do this but nowadays, but that's how people started thinking about it. Let us stimulate all the nerves, they tunnel in the middle and put a battery to the right side of the upper back or chest. So that's how people kept thinking about how can we improve our peripheral nerve stimulation to cover indications we're unable to accommodate by current, at that time, neuromodulation modalities. I would like to show you that's actually one of my cases that I did in about 2014. I was, at that time, we had this patient who had failed all kind of treatment for trigeminal neuralgia, including nerve blocks, physical therapy, radiofrequency ablations, glycerol injections, decompression surgery. Patient was in very severe pain, unable to live a normal social life or interact, perform her work. And then we decided to go, and at that time we used the spinal cord stimulator system for performing peripheral nerve stimulation for the trigeminal nerve. We placed one lead above the eye, the other one is below the eye, trying to capture both V1, 2, and 3 the best we can. And then we tunneled actually those behind the ear down and put the battery in the chest. And this patient had dramatic improvement after we did this, and she continued for, last I saw her, it was 2 years follow-up. Patient was very satisfied, was pain control, back to work, back to normal social living and family life. That's another example of a case, all done by old system that were not adapted to the using peripheral nerves, but here we put 2 leads to stimulate the C2, 3 area, trying to capture the cervicogenic, basically headache, by capturing the occipital nerves. And we tunnel the leads down to the back. And patient continued to have improvement. This patient has now a follow-up of about 9 years. I changed the IPG for the patient 3 years ago, and patient continued to have very good improvement with the device. So peripheral nerve stimulation in all kinds of studies showed very promising results since the earlier studies and for quite a long time. This is another case I performed where a patient had very resistant intercostal neuralgia. We tried with this patient everything: medication management, physical therapy, and we tried nerve blocks, radiofrequency ablation. Nothing provided good relief for the patient. So we decided to go with peripheral nerve stimulation. So that was a wireless system. As you see, we just implanted the leads only, put the contacts close to the nerve to provide the desired stimulation. And then, so there was no implanted IPG, which made it easy here because those 2 leads are far from each other. But we had an external antenna that coupled and interacted with both leads and provided the stimulation needed for the patient. One of the advantages of the wireless system is in that, number one, you do not implant a battery, which again carries all the risks of infection, site of battery pain. And of course, those patients will have to go every 5 to 7 years for another surgery to change the battery. So once you have a wireless system, if the external generator goes bad for any reason, you just need to buy another generator. You don't have to expose the patient to another surgery. So that's an example of a case that the wireless system was extremely helpful in addressing the pain. I would like to get your attention to some of the very important targets for peripheral nerve stimulation, which are the superior cluneal nerves. Many times I always wondered, since I started my training in pain management, the patient will come saying, I have pain, and they point at the iliac crest. And for, again, long time, we always found that we do epidural steroid injection, they do not work. We do medial branch blocks, facet joint injections, nothing work. And then you wonder, what then should I do? Until all the new studies and anatomical studies review articles started talking about the superior cluneal nerves as a target for many procedures, nerve blocks and peripheral nerve stimulation. And if you really go to your clinic and start examining patients, you'll find good number of patients who will point to their pain in that area above the iliac crest, and they will not respond to the other interventions we do, again, like the epidural injection, facet injection, or medial branch blocks, radiofrequency ablation. And I personally performed a good number of peripheral nerve stimulation for those nerves with great success. So again, we do a diagnostic block. We go on the iliac crest, inject those nerves. And then when the pain improves, we move to the peripheral nerve stimulator trial for a week. And then we move to the implant, and those patients get good relief for their pain. You need to identify and recognize the course of the superior cluneal nerves, because it's variable from their origin in the lumbar spine down to the gluteal region. But it's very well known that targeting them as they go on the iliac crest is a good location to identify them, block them, and stimulate them, because we know that at that point they are just going on the iliac crest. So become an easier target to block at that point. Here's a patient where I stimulated and I placed a lead on the superior cluneal nerves. And as you can see here, we went slightly above the iliac crest, but again, you can go on the iliac crest. And the reason I put it slightly above the iliac crest here is that the patient complained of pain slightly above the iliac crest. And as we mentioned, the superior cluneal nerves run a course between the lumbar spine to the gluteal region, so you can target them anywhere in between. So recognize those differences. That's another very important indication, which is the sacroiliac joint. So typically we put one lead medial, one lead lateral to the sacroiliac joint. You can put only, if both sides, you can put one lead just medial to the sacroiliac joint, basically stimulating the middle cluneal nerves. So the middle cluneal nerves provide innervation to the sacroiliac joint. As you see, and as we work on the sacroiliac joint, we focus mainly on the posterior innervation of the joint. So through our nerve blocks, through our other procedures, same like for peripheral nerve stimulation here, we do provide stimulation for the posterior innervation to make sure we get pain relief. You go through the same steps. You do a diagnostic block, and then you do the trial, and then you do the implant. So you take those very careful steps to make sure that when you perform the implant, you will yield good results. That's another indication for the genicular nerves. And actually, we do them in several ways. This picture is not actually a case I did, but some people will put them across the femur. So it goes basically around the shaft of the femur, trying to capture the genicular nerve. Same here for the tibia. Or if you look at my cursor here, I personally put a lead next to the bone here, and another one next to the bone here at 50% depth. and one down here again at 50% depth, trying to target the genicular nerves in the same way we do the nerve blocks as in a common approach. But I know of some who will put it around the shaft to basically try to get stimulation around the shaft. And there is justification for doing it either way. So implanters who put it all around the shaft, thinking there's big anatomical variability in the location of genicular nerves. That's why they want to stimulate all around the shaft to make sure they capture and adjust for this anatomic variability. When you put them just next to the shaft at 50% depth, those leads also provide stimulation at good range, a few centimeters on each side, again, will capture this variability. So peripheral nerve stimulation requires a lot of thinking and engineering to be able to identify the appropriate nerves. This is basically the anatomy of the sural and posterior tibial nerves. If you look here, and these actually were the first cases I performed by peripheral nerve stimulation. I had a podiatry team that started sending those patients my way. They control the innervation of the foot. That's why if you do nerve blocks and pain improves, then put peripheral nerve stimulation, one lead at each nerve. If you have it bilateral, I would recommend you put a lead at the posterior tibial nerve on each side, because that controls more innervation of the foot than the sural nerve, which controls only the lateral aspect of the foot. So you have to try to capture, I would say, the nerve that provide a bigger innervation in the painful area, so you can. And as I'm speaking in most of my conversation here, I'll be talking based on the regulation we have in the US, but I know in other countries they can place 3 and 4 leads. So they be able to place maybe more leads to provide better coverage for bigger area. But again, this is variable between different countries and insurance coverage. I'm just trying to give you some sense about our experience in the US and what we can and we cannot do. We find that this is also very helpful in when we stimulate the posterior tibial nerve in cases of peripheral neuropathy of multiple origins. So when we put one lead on each side for the posterior tibial nerve, we found great improvement in peripheral neuropathy in the feet when we do this. And that's a case of the sural nerve stimulation that I performed for one of our patients. As you see, I did it with ultrasound, but then I routinely will take a fluoro image just to make sure I have both images. The fluoro image in the patient chart can be clearer than the ultrasound image sometimes, so that's why I do both. Again, that was a wireless system. We placed it where it should go. Usually, sural nerve is identified between the lateral malleolus and Achilles tendon. So that's, as you see, that is the anterior image, and this is the lateral image to show you it actually, yes, it does present between both of them when identified. This patient actually now had it for about 3 years and continues to do very well. That's another patient I had who had ilioinguinal neuralgia in the groin, which was a completely difficult case, failed management by everything for several years. And then we did peripheral nerve stimulation, again, under ultrasound, and I took x-rays, tried to provide stimulation as much as I can to the area. This patient now, again, 3 to 4 years, doing very, very well, with no more complaints about pain in that area and without any loss of efficacy or decline in efficacy. So at the end of my talk, I would like to tell you my philosophy when it comes to peripheral nerve stimulation is if you can numb a nerve, you can block a nerve in the body, then you can perform a peripheral nerve stimulation on that nerve. As long as you can identify the diagnosis, perform a good nerve block, you identify the nerve that is the source of pain, then you can definitely put a peripheral nerve stimulator down there on that nerve. Again, under ultrasound guidance, under fluoro guidance, anatomically. And it's very important to notice that all peripheral nerves has a description of being blocked anatomically using ultrasound or using fluoro. So make sure you just use the approach that you're comfortable with. If you do them anatomically, do them anatomically, but I encourage you to take a fluoro image at the end to document the placement and to confirm your placement. If you're comfortable with ultrasound, then use ultrasound. You will be able to see the nerve dynamically and be able to put the lead next to it. But if your ultrasound skills are not great, that shouldn't render you from actually performing the procedure, because as I mentioned, every single peripheral nerve have a description about how can be blocked by fluoroscopy. So just perform the nerve block under fluoroscopy, use same approach to identify the nerve under fluoroscopy. Usually during the procedure, both trial and implant, we will do nerve stimulation to make sure the patient is getting the tingling and the paresthesia at the site of pain, which confirms to you that you're close to the nerve. So by using images, by using stimulation on the table during the trial and implant, you become very confident that you are close to the nerve and be able to stimulate it. Again, thanks so much for the opportunity to present to all of you. And again, I regret not being there in person, but I'm glad I could continue to share my presentation virtually. And that's my email address on the screen, and I will leave it on all my talks. Please, if you have any questions, if you have any comments, if you have you would like to connect about anything, please feel free to email me after the conference, and I'll be very happy to chat with you and answer your questions. Thank you so much.